excited to participate, largely because I'm not in medicine or healthcare. And I think in many ways, this past year has given us all a great deal of insight into how critically important healthcare is to each of us and our families. So I'm probably gonna ask some stupid questions that general public would ask, so hopefully that'll be helpful. But please, I encourage you to ask questions and engage with our panelists. I don't want to take up too much time, but I'm really excited. There's a couple of panelists here that I went to school with and know and really proud of. And I want to start by allowing them to introduce themselves, give you a little background. And I'm going to start with somebody who I'm meeting for the first time, but I've heard about in some ways because he's a bit of a trailblazer. He's at least was at Sidwell before me, which means that you know, he started a long time ago. But Jeff, why don't you introduce yourself?
Yeah, Jeff Mazique, class of 1970, the original one Afro-American student who went to Sidwell. And now, to be crude, I'm a hired gun. I'm a doctor. And for the past 40-something years, I go where the need is greatest. So basically, for the last year, I've been the COVID doc up on the Sault Ste. Marie reservation up in upstate New York. So I do COVID among other things, but it entails, I work pretty much 7 days a week, 70 hours a week, and read about 5,000 COVID articles and spent about 2,000 hours on COVID in addition to seeing patients. And I have to give a shout out to one of your students at Sidwell, Alexi Weinberg. And I met him through a previous Zoom, and he's been working with me ever since I've been up here. And he is a great student. He's been a great help. He's going to be a great doctor, and he's turning out some good products. And he's kind of helped me out doing the stuff I do.
That's awesome. That's awesome. Jeff, thank you. I'm going to next move to someone that I know personally. And while I recall her being one of the best athletes that I ever saw come through Sidwell, I understand that she's now one of the best doctors out there. Jocelyn. You're on mute, Jocelyn.
There you go. Thank you, Neville. I'm Jocelyn McClain. I am an anesthesiologist, and I am working right now in Central Illinois, about 2.5 hours south of Chicago. I am class of 77.
All right, thank you. Let me go to Phillip, another person that I had the pleasure of going to school with, and I've seen a few times since that time, and I'm glad that you're on board here.
Thank you, Neville. I'm Phillip Proctor. I'm also class of 77. I am a urologist here in the Washington, D.C. area. I've been in practice for about 28, 29 years now.
I'm looking on my board. Natasha, introduce yourself, please.
Hello, everyone. I'm Natasha Bonhomme, class of 2001, what my class always called the true first class of the new millennium. I am founder and CEO of Expecting Health, which is a nonprofit at the intersection of health policy, health communications, and emerging technologies with a particular focus on maternal and child health issues and genetics and genomics.
I think I understand. You were speaking English, right? Thank you for laughing. Amanda, I'm gonna come to you next.
Thanks, Neville. I'm Amanda Castell. I'm class of 1991. I'm parent of a senior and a freshman at Sidwell. I am a pediatrician, a preventive medicine physician, and an infectious disease epidemiologist. And I'm here in the DC area and work at George Washington University. I'm a professor of epidemiology there.
Ooh. All right. Well, we're going to have a lot of questions for you. We're going to need to do something with your volume. Maybe, I don't know if you, but we'll work with that. Robia, who I just met a little earlier today, and I said your name right?
Robia.
Roby.
Yes, that's okay. Good evening, everyone. My name is Robia Smith-Herman. I am class of 2007. I am a licensed clinical social worker. I work as the team leader and field educator at the Renfrew Center in Radnor, Pennsylvania, as well as an outpatient therapist at the Center for Hope and Health in Ardmore, Pennsylvania, and I am located in the Philadelphia area.
Thank you. I'm going to go to Kai. Did I caught you? Yeah. Go ahead.
Yes, you got it. Hi, Neville. Thank you so much. So you don't know me, but I do know you. And I fell completely in love with you at the last conference last year. So just so you know, I'm glad that you're moderating this panel. My name is Kai Parker. I am class of 1998. I'm a naturopathic physician. I'm a doctor of Oriental medicine and a certified professional midwife. And I am also local.
And the last panelist here, technically not an alum, but I think she takes care of current students. So that sort of grandfathers or grandmothers her into the Alumni Association, Jasmin Whitfield.
Hello, everyone. Yes, I guess it does grandmother me in. So I do take care of all the students at Sidwell. So I'm the director of health services. I'm a registered nurse. So my background is really community public health nurse. My specialty is really urban public health, and I was actually originally from New York. So definitely near and dear to me in terms of working with urban environments. And I've been at Sidwell now for 14 years, but I've been a nurse for over 20. So thank you.
Well, I was gonna say, you make sure that students get to become alums. That's
I do. Exactly.
Very important. Well, you know, I have to kick this off, and I think I want to start with you, Amanda, given your background. Obviously, the major story over the past year has been COVID-19, coronavirus, and all of that. Could you take us back a year and bring us to the current in terms of what has happened?
That's a big question, Neville. I can tell you that, yes, at this time last year, I think most of us were packing up our offices or being prepared to be sent home for an indefinite period of time. It's hard to imagine. I was just finished clinic this afternoon, and I'm a volunteer physician at the DC Department of Health in their Health and Wellness Clinic, and we were half joking, half lamenting about how much we've learned over the last year about this novel virus, how much we continue to learn, how maybe somewhat naive we were at the beginning, thinking, well, this will last a couple of months or, and then we'll get back to life as we knew it. And unfortunately, here we are, really celebrating, or I don't know if we're celebrating, but we're marking the year anniversary of the pandemic of a century, of a lifetime, that has really forever changed the way that, we will operate as a society, and as all of us as healthcare professionals has certainly changed the way that we think about life and delivery of healthcare and how we sustain those people that we try to care for on an individual basis.
Now, have you been working on anything other than this over the last year?
So I pretty much put my work, so before the pandemic, my work focused on HIV and related co-infections. And essentially on March 14th of 2020, I decided that our health departments were under-resourced and that our hospital systems were sufficiently resourced. And so I pretty much dropped what I was doing and started working with the DC Department of Health, doing case investigations and helping them manage the epidemic. here in the DC area. And I took a pause from my clinical work until actually just this past January. I went back into clinic, and my research has continued. Thank goodness I have a great research team, but it also has pivoted to include aspects of HIV and COVID, which I'm sure we can talk about later, but obviously with all of the inequities and health disparities that we're seeing with COVID, those of us that work in the field of HIV have seen it all before, unfortunately, for decades. And so there are a lot of lessons learned that we are trying to apply in our response to HIV to the response to COVID.
You know, I've heard similar things from other friends who work in HIV, some of the similarities in that regard. Jeff, I want to come to you because you mentioned something in your introduction about sort of being the doctor for hire. And it sounds like you really took on a very unique challenge. I mean, how has this past year been for you in dealing with COVID?
Okay, when I started here, it was very calm. You know, what had happened, see, when you're a new kid on the block, they said, let him go in and test all the people. We're not going to risk our lives. Let the new guy in there and test everybody, right? So, okay. So things were calm till about June. Then college students, whatever, it exploded. Everything exploded. So we became a hotspot, right? So we transitioned from just testing people to actually triaging people, who goes to the hospital, this, that, and the other. And then now we've pretty on the res is pretty good getting a vaccine. It's pretty easy getting a vaccine, you know, if you're a native. But now we got long haulers. Long haulers are people, 55% of people who have COVID have persistent symptoms. And what happens, there are no real treatments. And so we're kind of fumbling around. And what I always tell everybody and the students, which a lot of people don't recognize, is the fact that when it comes to medical data, you have data on whites, blacks, Hispanics, Asians. You have very little data on natives. So you're really not sure how the treatments, you're really not sure the presentations. I don't want to go on too long, but to give an example, you know, you may know what a pulse ox is. They put it on your finger and test your oxygen, right? Study came out, pulse oxes don't give accurate readings on Afro-Americans or anybody who has color. So it may read it's normal, but it's not really normal. So every day is an adventure. Every day, you know, I do a COVID report every single day for the past year. And every day there's new stuff, different stuff. And what you thought yesterday may not hold true today. So, yeah.
Does anyone else who I know doesn't necessarily work in infectious disease want to speak on how COVID has impacted your practice over the last year? All right, well, I'm gonna pick on you, Kai.
Yeah, actually, I was about to raise my hand. My practice has definitely changed. I remember when I found out that we were going to be moving out of the office and into my basement where I am right now. I figured I was out of business. I'm a midwife who can't touch babies, can't touch bellies, can't hug mommies, can't welcome families in person. And I just thought it was going to be terrible. And the opposite is true. I am able to serve a lot of people who don't want to go to the hospital to have their babies. To bring another piece of it in. Right now in DC, some of you may know, we are in the middle of a maternal mortality crisis. Black women and babies are dying. They are not being cared for properly. And it's out of proportion to the rest of the society. So we are seeing a huge influx of people who are interested in home births, so they do not have to go into hospitals. I used to get maybe 1 or 2 calls a day. Now I'm getting about 6 or 7 for midwifery every day. And it's different because I used to just attend births of people who are home birthers, people who know about home birth, they've educated themselves, they're ready for the experience. And it's amazing, right? And now I'm getting home birthers who are not necessarily home birthers, who don't really want a home birth, but they do not want to go to the hospital. So instead of getting people who are really, in love with the idea and making this decision from a space of love, we're getting a lot of people who are making this decision from a space of fear, which is interesting. But my practice has never been busier. Trying to serve as many people as I can, and there is a shortage of us. I typically have 1 student at a time, and I will take her through the program, and then I will take another student. She will become a midwife. Right now I have 5 students because we are trying to get as many people serving these women and these families as possible. There are a couple of other differences. Right now, typically people would be coming into my office and I would be caring for them face to face. Right now, I'm sending every family a Doppler, a scale, a blood pressure monitor, urine test strips, urine specimen cups, and a tape measure. And what that means is I still spend the same amount of time with them, but their partners are becoming my hands. So whereas they're going in for their blood work, they're going in for ultrasounds, they're going in for everything that needs to be done in person, our visits, just the regular prenatal visits, are happening on screen, just like this. So the first visit is spent training their new doctor partner, and their partner learns how to use the equipment, and we do our visits that way. So that's different. The other piece of what's different is what I get to wear to work. And I actually just finished with my last patient right before this, so I actually can show you guys. So on the top, of course, I always look nice, right? I do shower, I do try to match. However, I will show you, because there's no shame in my game, that I do come to work very comfortably. These would be sleep pants. And I like that part of what's going on right now. But things have changed. Things are definitely different. We're rolling with it. We can't control it. So, for me to minimize suffering, I accept it. And I'm doing the best that I can to be present in the midst of all of it and share as much of that with my patients as I can. So,
I'm curious, Natasha, you, as I said, I know you were speaking English, and I heard a couple of terms, and I heard something about genetics, something like that. Now, does genetics have any impact on COVID treatment, COVID mortality, any impacts as far as that's concerned?
Yeah, that's a great question. For
well,
us,
thank you.
And you picked one of the bigger words, genetics. I thought you were going to go with maternal, but you went into the deep end. So in terms of genetics, I would say I'll approach that question in two ways. One is, when people think of genetics and genomics, they think of a lot of research and a lot of cutting edge technology and what's happening there. And during COVID, a lot of efforts that we thought were really far away or very novel, we had to pivot and really have, all hands on deck when it comes from the research enterprise around really addressing COVID. And what you learn in genetics can definitely apply to that. As related to my work, where you see gaps in healthcare, you see them in all the topic areas, whether it's lack of access to genetic services or lack of access to COVID testing and now COVID vaccine. It's still the same story. So it may seem like a different topic, but the issues are still at hand in terms of the disparities that are there and who gets what treatments and what interventions and education. So we've been partnering with a lot of our community-based organizations to say, what are the health messages we can get out there? It's really exciting. I don't mean to sound preachy, but it's exciting that we have a vaccine now, but we know those who tend to get things first have gotten this first, and those who tend to get things last are still trying to figure out how to get testing and vaccines. So we are working with our partners to try to address that. And I think that's been really hard and challenging. So we've pivoted a little bit. Our messages aren't just genetics, but we know if something runs in the family, if you have hypertension in your family or diabetes in your family, we know that we've seen an increased impact of what COVID can do in those families and in those communities.
Well, I will raise my hand and say I have been vaccinated. I had my second Moderna shot a couple of weeks ago. So, I'm all for that. Jocelyn, let me ask, if I remember, you said I can't say that word, but you're the person that puts us to sleep before surgery, is that right? Is that the?
That is right.
Okay, so has COVID impacted what you do or choices that, there's a part of me that thinks, well, other than COVID, hospitals didn't do anything, everything stopped. And so therefore we weren't needing an anesthesiologist. And what's been the impact on your profession?
So initially, when COVID started, the directives came through for any patient that needed to be intubated as a result of COVID, that the most experienced person in the hospital does the intubation, all of the intubations. So as before COVID, we trained people to do those intubations. We trained the respiratory therapist and what we call airway managers. So this changed because that means every patient that came into the ICU that needed to be intubated had to be done by us. So that just really made things kind of go very chaotic. And quite frankly, it was very scary in the beginning because there wasn't enough PPE. And because there wasn't enough PPE, we were told, you go up there, you intubate those patients, and we don't have an N95 for you, but you figure that one out. So that was the most stressful period for me. My hospital, or I should say my department, was given N95 masks by a construction company. They donated about 500 N95 masks. And so we were wearing those until the hospital administration said that we were not allowed to use PPEs from outside the hospital. That created chaos. So at one moment, I was told to go intubate a COVID patient. And if I put on that N95 that was given to us from a construction company, that I was going to lose my job. So that was in the very early weeks until you recall our Surgeon General was an anesthesiologist and came through our American Society of Anesthesiology and started putting out directives like minute to minute. I was following them because I was risking my life going. And when you intubate a patient, you get everything that comes up from their respiratory system and aerosolizes into the room. So you're at very high risk. So it was probably about a 2 to 3 week period in there that it was extremely scary. No PPE, and this threat that if we used N95s from an outside source, that your job was at risk. So it passed gracefully.
I was going to ask, in general, did any of our panelists have did anybody get COVID or have any family members that they got exposed to? What was that like? Well, I mean,
So
what did you do? I mean, that seems scary to me, the idea that, you know, somebody I know has COVID and now, so what do I do?
Well, so my mother got COVID. I will tell you what I did. My mother had COVID, and my mother is 77 years old with Parkinson's. So we didn't know what was going on with her at the time because she had been in my house. She lives with me, and she'd been here, and she'd been fine. She hadn't been anywhere. She hadn't been outside. Well, she'd been outside, but she was like in my backyard and not exposed to anyone. She had some difficulty breathing. We sent her to the hospital in an ambulance. They didn't let us go. And when she got there, they told us that she had COVID. No one else in the house had COVID. None of us had it. So we have no idea where she got it, how she got it. But she was in the ICU for about 6 weeks. And they told us that there was a very good chance she was not coming home. They put her on the end of life list. And thank God, I was able to go see her. And I had hazmat suits that were gifted to me from somebody who was a blessing. So I would go in fully hazmated and do her nails and do her hair and put music on lights in her room. And I was painfully aware that I was the only person walking into the hospital to do that because there were no other visitors allowed in the hospital. And because I was a physician and because my name was on her chart, I was able to go see her. And I know that that's what made the difference because my mother's here. She's here with us now. But so many other people don't have that opportunity. And just to answer the question in the spirit that you asked it, none of us got it. None of us had it. So, you know, lots of mysteries here.
Amanda, were you raising your hand? Did you have a personal experience?
Well, I mean, my story is much less minor than Kai's, and I'm so glad that your mother recovered, and I hope she's doing well. So I have a stepsister who actually is in nursing school, but decided that it was too stressful at this point in time for her to continue her studies during COVID, online. It's hard to learn how to care for people, as Kai was saying, through Zoom and online. And so she actually took a leave of absence from medical school and was working at Trader Joe's. And we all know that, those were kind of the most vulnerable, the essential workers, who were helping us get our groceries. She said that, people came to work and they had things like an eye infection, but didn't realize at the time that that might be actually a sign of being infected with COVID. And so unfortunately, she ended up getting sick herself. And she did have obviously it was not as severe as the story that we just heard, but she's relatively young and healthy, and she was out of work for about 2.5 to 3 weeks, just trying to recover from it. So it's scary, and you worry every day. And I think Jeffrey was talking about the long haulers. We really don't know what the long-term side effects are, and we really can't predict who's going to be a long hauler. So we continue to watch and be hopeful that she will, have a full recovery and be fine.
So, Phil, I'm gonna come to you. You've been quiet here, so I don't want you to think that I forgot about you. But refresh my memory. What's your specialty?
I'm a urologist.
Got you.
Uh,
I was gonna say, clearly this has been a major health crisis that we have experienced. Can you just in general put in perspective from a medical standpoint? I mean, even though you may not necessarily work in infectious diseases, I'm sure that you have some particular insight just as a good doctor.
Well, probably the biggest impact is that it has forced us to reevaluate how we practice medicine in many ways. As a urologist, I'm a surgeon, and I'm very hands-on. And so in the beginning, there weren't very many directives to tell us what to do. We did not do telemedicine. It was not reimbursed, so it's not something that we could, I can't examine a patient over the telephone. So we had to quickly convert to telemedicine. And then the directives came that you couldn't do any elective surgery. And that in itself was extremely stressful, because if you have, like in my job, you have a man who's facing the potential with prostate cancer and who needs a biopsy. And then you're telling them that we can't do your biopsy until I don't know when. And then even when you have other procedures, no one wants to go in the hospital because you can't even get into the hospital unless it's a dire emergency. And so it forced us to really perform medicine in more creative ways, but at the same time to be as best you can for your patients. And a lot of that still exists, even though we don't have the constraints like we did before. But we're still seeing the fallout in terms of hospitals still getting back on track to full capacity. Still, there are shortages of supplies. We have to deal with whether patients come into your office who forget to tell you that they were COVID positive, or that perhaps they've been tested and they have not received negative results. And so you're still very vulnerable, not only for you, but for your staff and then for the other patients who are there. So it's had a great impact and continues to do so. Every time we schedule surgery, patients have to get COVID tested before their surgery. And so there's a lot more pieces to the wheel that we have to sort of consider that we didn't before.
Jasmin, I want to ask you in particular an issue that I don't have children, but I can only imagine what it must be like for dealing with that demographic, both as a parent and as an educator. I mean, there seems to be a lot of different stuff being said about the impact on children, whether they can pass it on, how old, all those sorts. And then not to mention, it wasn't that long ago that I was an adolescent myself. And, I can't even imagine, telling me at 14 or 15, not to go, chase around with my friends or not to do this. I mean, what is, and I'm not even certain, is Sidwell even in a hybrid or half or all? I mean, just what's it like been with those young folks?
Oh gosh. So I don't think we have all night, but I'll certainly try to summarize it for you. So I mean, it's been difficult. I mean, certainly in terms of I have a great team, so it's not just me, which is certainly helpful. But a lot has changed in terms of the interactions that we have with the kids. I've always strived to try to make as many connections as possible. Our office was actually really a hangout spot pre-COVID. And you would say, why would you go hang out in the nurse's office? But that's just who we were. I mean, that's how I got to know kids. That's how they honestly taught me. I could figure out how to advocate for them because they were always in the office talking about all sorts of things that they just needed to vent, or they wanted to talk about their day, and they didn't have that anymore. Once COVID hit, I had to restrict who was in the office. We started off in distance learning. Then we were able to move to a hybrid. And even with the hybrid, I'll tell you a funny story in a moment, but it was difficult to say that the kids couldn't come to the office like they used to, that they had to be called in just to make sure that there wasn't anybody else there that maybe we were taking care of that could probably expose them. And they asked that when we were meeting with them to talk about some of the rules, the health and safety protocols before they all came back. And some of the kids that were usually in our office, like, can we come still see you, Nurse Jazz? That's what they call me. And I was like, you can, but not in the same way. Maybe just do like you knock on the window, give me a wave, and then keep going. But I don't want you to come in because I just never know what's there. And one of our kids that, famous, always coming in for resting and that sort of thing. This is the funny story. Really, I didn't realize how much of a connection he had with us. He was there all the time. But we had called home just to talk about, some care coordination pieces like chronic health conditions, things like that, just checking in. And his mom was like, he has your birthdays on the refrigerator. And I was like, are you kidding me? And I was like, oh my goodness. And so came back to school, literally climbed the tree that is outside our office and did a wave just because he knew that he couldn't come in. And so those connections that we used to have, I'm not able to develop them the way that I used to, which is sad for me. Especially the new students that have arrived. I feel really a concern for them that, that I hope that, every child that starts school, they have a person, right? And sometimes that has been my staff that has been in the office. So we had to find other ways to connect. So that was with, arrivals. You see us out in the garage, Amanda could probably tell you, certainly when they pull up in the garage, we have all little, like as many little conversations as we possibly can, talk about their outfits when they get out of the car, whatever it is to try to figure out how to connect in some way because we can't have them in the office. So, in terms of like their medical conditions, certainly seeing a hit there and how they manage them, it's difficult for them to do that when they're at home and hybrid, just trying to figure out how to manage it all. Certainly the mental health side of it, right? Because they are disconnected from their friends. So it's difficult for me to say, keep your 6 feet, don't hang out with your friends this weekend, but try to figure out how else you can connect to do that. It has changed dramatically. So, we continue to find different ways of how to connect with them, with personal phone calls, stopping by class, checking on them when they're outside for lunch, whatever the case may be, but trying to reassure them that it may feel and look very different, but that we're still there for them. So whatever it is, they can call, they can Zoom in, we set up Zoom calls and things like that. That has actually been the positive, I will say, in terms of how we care for students now, is that we really can have a real conversation around the whole child. Typically, we were just able to just kind of get to what the issue was. but now we can meet with the entire family because nothing is stopping them from being able to Zoom in. So they can call from the car if they're commuting to work. But I can get the whole family now and actually be able to talk about what exactly is the issue and what's getting in the way of their learning. So that's a positive. But it's been challenging. And then certainly for me, my job responsibility completely changed when COVID hit. So it's hard to hear some of the stories from my team when I'm like, oh man, I used to be able to talk with that student every day, but it's different now because I'm in Zoom meetings and trainings all day long versus really being with the student. So sorry, I'm rambling there for a moment, but it's just when I get to talk about the kids, it's obvious that I've been there this long that I have a true connection with these kids, and they come back and they talk about the health center at my school is not like this one. I'm like, that's right. You'll remember us forever.
Oh no, that's wonderful.
Yeah.
That's wonderful.
Yeah.
Here, I'll give you the care emoji.
And well, can I just add that Jasmine has been the shining star of all of the COVID activities that have been occurring at Sidwell. I mean, she and her team have been phenomenal. And we are so lucky that we have her and that we have her and her team, because I didn't realize before that many private schools don't have a nurse. And they were all scrambling to try to find someone who could do this work. And Jasmine has just been amazing, I have to say.
Awesome. So let me mess up your name again. Robia?
That was right, Robia. Yeah.
Boom. So I saved the best for last here, I guess I would say. But so tell me, how has this affected your practice? What's your specialty again?
Oh, so I work in the field of mental health, and yes. So it has dramatically affected our practice. We had 48 hours essentially for our training department to, at my primary job, to figure out how to translate an entire treatment program for day treatment level of care, so partial hospitalization, intensive outpatient for eating disorder patients who have co-occurring disorders that range from post-traumatic stress disorder, depression, anxiety, personality disorders, the whole 9 yards. We had 48 hours for our training department to come up with our program to move to virtual, for us in leadership to train the staff, and then for me to tell all of our patients, hey guys, everything's about to change. You're going to be doing program from home. Here's a packet that I need you to read by tomorrow, and I will see you on the computer. And one of the things about therapy that is really important is the connection that you get with someone when you sit in the room. And for the last year, we have not had the ability to sit in the room with a patient. And so, we've gotten really good at reading nonverbals in just this little square, but what we miss out on is the opportunity to see a lot of these little nonverbals of, a foot tapping or fidgeting with your hands, or something that in my practice, it's that little nuance that I can pick up on and say, hey, what was that? Can you tell me a little bit more? And that's been difficult because, when you have, and my site, I'm one of 19 outpatient sites within my company. When we have 30 patients on the screen and we're trying to figure out if everyone ate their lunch, and we can't see some of these little nonverbals, it's very, very difficult. And on top of that, as Jasmine kind of indicated, the mental health aspect for especially our adolescents, the physical distance and the social distance has been very difficult to work through because particularly with eating disorders, the isolation, we've seen a significant increase in eating disorder diagnoses over the last year. As we probably all can take a guess, we've also seen an increase in depression, increase in anxiety, increase in post-traumatic stress disorder, a lot of grief that has come through, self-injurious behavior is up, suicidality is up. And when you can't see any of that, it makes practice so difficult. So we've had to shift absolutely everything. And I also educate students. So I take graduate students who are studying to be clinicians. And that's just been a very interesting thing to go through, because I'm essentially the blind leading the blind. I did not have a graduate course on how to do teletherapy. And so I'm now teaching graduate students how to provide the same level of mental health care through a computer. And it's difficult. It's really hard. Um, Again, particularly because the severity of all symptoms have increased overall, and to provide the same level of care and to make sure that our patients are safe, they're nourished, they are, getting what they need. Also, while trying to support my staff who are going through all of the same emotions that our patients are going through, and trying to train new clinicians at the same time in order to provide best practice. It's been a tough year, but I think it's throughout this whole learning experience, I've honed my skills on how to read a face and a shift of just, from chest up to be able to say, hey, what was that there? Can you tell me a little bit more about, what's going on? But yeah, it's been tough.
Well, let me follow up on that point.
Sure.
Do you, and I'm going to come to others as well. What do you sort of maybe see the long-term impacts? I mean, obviously you had to shift the way you were practicing to accommodate a need. Can you foresee this being permanent? Do you think things will go back? Will there be, what's your sense of the impact on what your profession?
Sure. I think, we will probably move towards some sort of hybrid model. One of the benefits of virtual therapy is that our reach is wider. So patients who would normally have to drive 2 hours to our treatment facility because we are the closest eating disorder facility to them can now Zoom in and get the same quality care. So we will probably still have some aspects of our treatment online, but it will, particularly for eating disorders, we have to put all of our patients in a kitchen and have them eat. We have to completely rework how that's going to look. We can't have the same amount of patients in a group therapy room and conduct group therapy the same way. I can't sit in my office and not be 6 feet away from someone. My office is a nice little cozy safe haven, and I'm right next to the patient. I have to rework my entire office to be able to have that physical distance and yet still create that closeness and that empathy and that support in a space. And it's going to be incredibly challenging. I think another thing that's important to keep in mind is the field of mental health is forever changed. We have people who are 14, 15 years old who have just had their lives completely shift, and even younger than that. And so if we think about this as, maybe for some it's a tolerable stress, for others it's a toxic stress. And if we think about the impact of stress on mental health long term, unfortunately, I think we're going to see 10 years from now, 15 years from now, people coming into offices and really struggling with maladaptive coping skills for emotion regulation because of this current year. And we are going to be, as mental health clinicians, dealing with this for years to come, because there's going to be individuals who, unfortunately in this current time, like I mentioned, eating disorder symptoms, all sorts of things have increased, who have developed these maladaptive coping skills for emotion regulation currently, and we're going to have to be able to continue to support them over the next couple of years to be able to help them kind of reconnect with their emotional experience, process this entire year that has been filled with collective trauma, grief, anxiety, depression, fear, uncertainty. And, it's going to be something that, again, the field of mental health is going to be dealing with for quite some time.
That anticipate with young people that you deal with as students manifesting itself in some potentially disastrous ways in the future?
I mean, I don't want to be super hyperbolic here, but I think that we do have to just think about, for many, this is, a significant life event. And if we think about significant life event as synonymous with traumatic event, think about, this is a trauma. And oftentimes when we are looking at the development of PTSD, acute stress disorder, all those types of things, we're going to be seeing the impacts of this 5-10 years from now still. And, you know, one of the things that even now, prior to this shift, I've noticed as a clinician, unfortunately, lots of people don't know anything about emotions. And so if we take that on top of this, you know, significant life event, we are going to have to do a lot of emotion coaching, a lot of helping children in particular and adolescents who have gone through this significant shift in their lives at such an early age really learn how to identify an emotion, experience an emotion, not numb out to emotions, and allow themselves to experience distress and teach them how to do so, which is a really difficult task. It's hard. I do it every day, and I have, you know, recently we just discharged someone in her 70s who had never learned how to identify her emotions, and so that's because of, you know, significant life events that happened in childhood. And so if we look at that as maybe a template, like that might be the case for some folks in the mental health world, but it's hard to learn how to experience your emotions, particularly if you are, you know, 7 years old and have no idea what's been going on.
Jocelyn, you mentioned how sort of your protocols had changed. Do you anticipate that going back? I mean, it sounded like there was even some tension with administration about that. I mean, what do you anticipate the impacts for what you're doing going forward?
I think, so that is passed. We have enough PPE now. I think, as Phillip alluded to, the number of surgeries that come into the operating room, we are still catching up from the times when elective surgeries had to go on hold. We are catching up, but we're still behind with patients who didn't get cancer screenings, patients who were afraid to come into their doctor's offices or into the hospital. So their cancers are more advanced now. So patients are also sicker because they haven't seen their doctors, they haven't continued their medications, they've come off of their CPAP machines. And then the other thing is long haulers, is that we'll see a patient who has had COVID in the past, and then they're responding just differently to the anesthetic, and we don't have an explanation for it. And we don't know when it's going to happen. Their respiratory system is just changed. So in some ways, we've done a good job. We've streamlined, and there has been improvement in how we triage who comes into the operating room and how we get cases done. But our patients are sicker. They're not taking their meds. There's long haulers and things that come up that are strange and different that we have to deal with.
Now, for the folks in the audience, remember, you can ask questions. We certainly encourage, before we get out of here this evening. So, I guess you can put them in your chat, or you can ask Anna, and we'll try to get to some of your questions. But Natasha, I want to ask you, now that we have seen or experienced this pandemic, and I hear a lot of comparisons to, I guess, the flu in 1917. I think that's when that was. But anyway, now that it's happened, can we expect this to happen again? Or can I say, okay, well, I'm good because it's not going to happen for another 75 years?
Another very good question. I always get very hesitant when people say this is a once in a lifetime thing, especially as a millennial who's had lots of once in a lifetime things happen, whether health, whether politics, whether, everything. So, but the difference from, in the early 1900s is we are just so much more connected now. Something happening across the world is happening here. It's just a flight away. And I don't say that to be scary, but just to say that there's a lot of good things that come with that, but also a lot of kind of scary things that happen. I would like to think that because of COVID and how much of an impact it has made, we will learn our lessons and do everything that we can to limit the impact that it has when it happens again. That this is what viruses do, and they're not going away. But I think that if we can really make sure that from a policy perspective, both nationally and internationally, really making sure we're monitoring, making sure people really understand health communications and the messages that come out. It's not just, Big Brother trying to tell you what to do. It's like these things really can make a difference. Washing our hands, wearing a mask, staying home. It can feel like a burden, but it can really make an impact. So yeah, but I tend to be a bit pessimistic, but I think I'm just going to be honest about that. But I think it will happen again. But I hope we can really manage it so that it doesn't become a year-long thing. But we can take it seriously from the beginning. And also, just to add to that, I think we have to make sure we don't forget the other. This may be a pandemic, but there are a lot of other epidemics happening. And earlier we mentioned maternal mortality, both here in the district as well as just across the nation. And so there's a lot of work to be done on the healthcare front.
I saw several of our panelists nod in agreement. And I would like to talk about health inequities a little bit. But before I do, I want to come back to Jeff because, Jeff, it seems to me, and I'd like to ask each of you this really, it seems to me that what you've chosen to do seems to me like that's some Sidwell Quaker tradition that's sort of been embedded in you to sort of, as you say, go where you're needed. Is that part of what came from Sidwell? Is that just you, or how do you think Sidwell has impacted your career choices?
Well, it's multifactorial. Again, my father decided to go into medicine because his sister died in the influenza in 1918. Okay. Again, my parents were very socially active, politically active. And again, I think that what happens, combine that with the Quaker mentality of Sidwell, kind of built on that, And so I carried that to Brown, which also had an influence. And I would say it had a great effect in terms of the Quaker philosophy of really looking out for those, even those who are very different from you. And I think it had a major influence, And again, is that it kind of taught you to think independently and walk your own path regardless. And like I said, I think that had a great influence.
How about you, Phil? What do you think Sidwell gave you in terms of your career choices?
That's hard to answer. I for as long as I can remember, wanted to be a doctor. So, and that kind of happened before Sidwell. I think if anything, Sidwell taught me, gave me the tools to be as prepared as I could be, and to not be afraid to pursue what I wanted to do, and to be confident that I was able to pursue it. So I think in that aspect of it, it sort of solidified my ability to keep moving forward, to always, respect my fellow man and the ideals of giving back to the community.
Amanda, what about you? How it was our fine Quaker institution impactful for your professional pursuits?
Yeah, what a lot of what Philip and Jeffrey said resonates with me. I always wanted to be a pediatrician since I was little, but certainly the values that were instilled in me while I was at Sidwell, the sense of community, the sense of service, giving back, resonate in everything that I do, I think, professionally now. And that's always kind of in the back of my mind, just trying to make life better for people in maybe just a tiny little way, but everything that we can do, every little thing we do helps them.
Kai, I have to ask you, it seems to me that, again, Sidwell and homeopathic medicine seem like that's a good fit.
Mhm.
So how did Sidwell, or how has Sidwell impacted you?
So if I may be perfectly honest, I never had plans of being a doctor. I never had plans of being a practicing physician. I had genuine plans of becoming P. Diddy, and I'm not joking. He was Puff Daddy at the time, and everything in me was planning on making a life that allowed me to be a music mogul. And I was living
Years
that life.
ago, a friend of mine asked me to say some MC rhymes. Okay.
Okay, so you may see behind me, right? This is the other part of my world, the other part of my life. At top, those are my 2 pregnancies and my babies, right? But down here, my sister said to me one day, she said, you know, Kai, all of my other doctors have medical texts behind them. You've got monitors and records. You might want to reconsider that. You know, one thing Sidwell did for me was it made me feel unlimited. You know, most of you don't know this, or probably none of you. I started Sidwell in 11th grade. I was the only one who was accepted that year, so I was the new girl in my class. I was in public school my whole life before I got to Sidwell. And when I got to Sidwell, you know, things were a little bit different than they were at Oxon Hill High School. My classmates and their parents were just doing different things. You know, I had a classmate who had a 5-story home with an elevator in it. And I remember walking in like, whoa, people are living like this. Interesting. Okay. And it made me feel like anything was possible. I just had to find it and go after it. Genuinely. That is why for me, becoming P. Diddy was not out of the question. I was living in New York. I was having meetings at Sony. I had a studio in my kitchen. I was raising artists. I was really making the moves to become P. Diddy. And one day I had a situation that was medical in nature, and I felt like it was completely mishandled. And it made me realize that I never again wanted to be in a situation where I had to put my life and my health in the hands of a doctor who basically was telling me what to do because I didn't have any medical knowledge myself. That is what led me to medical school. And even then, I still didn't mean to become a doctor. I went to audio engineering school after my first year, met my beloved husband, and I fell in love with obstetrics in the first day of the class. You know, it's a different path than most people take. Most people aren't waking up saying, oh, I think I really want to be a midwife. I'd love to wake up at 3 o'clock in the morning. I'd love to go to bed every night, not knowing if I'm going to like wake up tomorrow morning, but like 2 o'clock. But it is my path, and it is a perfect, perfect, perfect path for me. Now, getting back to the question, Sidwell, how did it influence me? So one thing I think is really, really important is, again, it made me feel very unlimited in what I could do. Even right now, you know, I am the only midwife who can legally attend home births in DC. I'm the only one in the whole city of DC who can do it legally. Doesn't mean other people aren't practicing, they are, but they're practicing illegally, unfortunately, because there's no legislation that allows them to do it. Now, again, standing on my foundation, I said, okay, well, this is ridiculous. That needs to change. So 3 of us wrote a bill, and that bill recently passed. So now certified professional midwives will be able to go to people's homes in DC and legally catch babies and not have to worry about whether or not their livelihoods are going to be challenged if something, you know, just attending the birth. So that's how Sidwell affected me. You know, that's not really Quaker philosophy, of course. You know, whoa, I will actually go into that quickly. Quaker philosophy, right? When I meet anybody who is coming to me for midwifery care, I always introduce myself to them as Kai, right? And I tell them all the time, I'm not the expert here. I am a woman who is, that's what midwifery means. Midwife means with women. I am just a woman who's going to be walking you through this. I am just a woman who happens to know a lot about childbirth, a lot about pregnancy, but you're the expert. You're the one with the baby in your belly, right? Being able to see people as equal, being able to see myself is very unimportant in this whole scheme of life, right? I am just there to be with people. And I learned how to do that from Sidwell. Sidwell taught me how to be present and how to be with others in a very real and very authentic way. So I'm very grateful for Sidwell for that.
That's nice, very nice. I like that. Jocelyn, I'm curious as to your insights about the influence of the Quaker education on your profession?
Um, I'm going to dovetail off of what Kai said about being authentic and being able to be with people, because in my field, I have about 10 minutes in order to get a history and bond with a patient and say to that patient, it's okay, you're going to give me your life to take care of for the next 4 to 6 hours, and I need you to be comfortable with me. So I am very comfortable talking with very different people. I think that they're comfortable with me, and I think it's just being authentic. I also think what Sidwell gave me is independence. I was very comfortable being alone. I was very comfortable in silence. I was, quite frankly, as a result of Sidwell, very, very comfortable not fitting in. It never bothered me. It doesn't bother me to be the only one in the room. It doesn't bother me if everyone is talking about whatever and I know nothing about it, or I know everything about it, but I just don't want to be a part of it. And so I think that's also part of being authentic. It also gave me that need to serve and to give back. And that's that, because I really want my life to lead. I want to lead with my life.
You know, you said something I didn't even really think about, other than I put myself in the situation of being a patient. And I think about, you know, when you see the anesthesiologist, that's, you're like a little, you know, a little, because you know what's, or you don't know what's getting ready to happen. And you're probably one of the last people that you would see, or a patient would see, before they sort of go off. So I'd never really thought. That's fascinating. Natasha, I want to get your feedback to that question too. Not that you have to be brief, but I do want to get one more topic in before we wrap things up. But tell me about, you know, the Quaker influence on you.
Yeah, I really echo a lot of what has been said, particularly, having worked in the nonprofit space for all my career and working with other patient support groups. People have asked me like, oh, what made you go into service? And I just don't even think of it. I'm like, that's just life. Like, that's what you're here to do, right? And I really kind of had to realize like, oh, that was instilled in me in part by Sidwell, as well as my family and just that. But to be able to come back to Sidwell in different ways and to hear people say, yeah, it doesn't matter what role you have or what title you have. It really is all about service. What are you doing for others, and how are you making the path easier for others, whether they're exactly like you or completely different from you. That is not a novel concept. That is just who I think we are. And that, that's just, to me, that's what Sidwell is.
Did I hear from you, Robia? Did we hear from you?
Not yet, but I do want to hop on this train, of course. I had the unearned privilege of being a lifer. So my parents, my mom's here, and so is my older brother. They allowed me to have this wonderful experience from pre-kindergarten to 12th grade. And I think when you go into pre-kindergarten and right off the bat, you are being taught those Quaker foundations, and also how to sit in silence for an extended period of time. Those are things that just stick with you. So my entire family, I have a younger brother who attended Sidwell as well. We were always at the Samaritan Inns once a month for our, family service activity. That was a part of, Sidwell. I was encouraged by so many of the faculty to start clubs and do things that were all in service of others. And so my father was a physician, my mother is a physician, and I did not want to be a physician, but I knew I wanted to help people. So how do you help people in such a way and not be a physician? You become a social worker, you become a therapist, you help people in that manner. And, I echo what Kai is saying about being able to be in that space. And when you were talking, Kai, the first thing came to my mind was Yalam, who is known for group therapy. And he says that you are fellow travelers. And my job as a clinician is to be a fellow traveler. I'm not the expert. I do have some knowledge, but I'm not the expert. My job is to be a fellow traveler and help guide you along your path. And I think that Sidwell does an excellent job of that. And I come back to, you know, one of the big things that you hear about Quakerism is letting your life speak. And I think being able to be a part of the Sidwell community from pre-kindergarten to 12th grade. And, you know, I have my best friends who I met in pre-kindergarten, and we constantly think about how are our lives speaking. And I think that that's something that is very much instilled in folks who go through Sidwell. And that, I think, is definitely what led me to be a therapist, because I think that that's the best way I can let my life speak.
Oh, that's great. I know we're probably going to run a little bit long, but I want to tackle one last topic, and that we've talked about a little bit tangentially, and that is sort of the inequities in healthcare. Obviously, we're all Black people here, and we also have the privilege of having gone to Sidwell and having some professional capabilities. But nonetheless, I'm sure that the healthcare inequities that you see generally impacting Black people must be exacerbated over the last year. And I don't know that I necessarily have a question as much as I'd like to hear just your observations of the impact, not only COVID, but just in general, how the health inequities are impacting our people. And I'd like to try to hear from everybody before we get out of here as sort of a final wrap up. And I hope the powers that be allow us this little extra time. So Jocelyn, I'll just come to you first.
So again, what I see is in my Black patients is that they've stopped medications. They haven't been able to continue things, and I think they're mistrustful. They're distrustful of their physician. So usually, what I'm doing is guiding them and what they need to say. When you go back to your physician, say to them, "This medication makes me cough. I need you to switch my medication because my blood pressure is still high." They tend to be passed off, and they say, "Okay, I'm coughing on this medication, so I'm not taking it." So the disparity is they're pushed aside, and they don't know how to advocate for themselves. And it happens over and over and over again. Here's what I need you to say. Here's how you say it. And please be persistent. That's just my observation.
Sure. How about Natasha? You speak on that subject of health inequities in our community, in our Black community, I would say.
Yeah, you know, it definitely has come up, and you know, I think that it just shows that there's something about the combination of COVID and then also, you know, a year ago or some change, you know, everything with George Floyd and people really waking up. And while I think that's good, I think another burden was, it took seeing the system not break, but the cracks to just be exposed through COVID for people to realize, oh, wow, the Black community is really unhealthy. What's that about? Whereas us who've worked in it and have experienced it and lived it are like, oh, it's just now you're noticing that? And the barrier isn't what's wrong with us, it's what's wrong with the system. And to have that, and then to have George Floyd, and then to have all these other examples, I think has really shown all the work that needs to take place, and for people to start having really honest conversations in lots of sectors, which I think is great. But that's hard work, and it can be emotional. It's another thing that we are dealing with as a community. Now it's, you know, some people are like, oh, now I'm ready for this conversation. Like, we're tired. We're trying to just survive. So I think that, not to go on such a tangent, but I think there are just a lot of layers to this. But I try to stay positive. I think there's a lot of renewed energy, which is great, around these issues, and to really, how are we addressing these disparities? But it takes everyone's voice. It's policymakers, it's clinicians, it's families, it's patients themselves to say, this needs to work for me. And I'm not the problem, but there is a problem. So how can we address it? And how can we really move forward?
And how about you, Phil? Anything to add in terms of health disparities? I imagine that in some cases, Black men probably feel more comfortable talking with you as another Black man about the issues pertaining to urology.
Right. Unfortunately, the health disparities didn't just start when COVID came, and we've been dealing with it for years. One of the challenges that I've put before myself in my profession is to not only give good service, but to be an educator for my race, so that we can at least close some of the gap through education and having the difficult conversations about their disease, the questions that they won't answer. Oftentimes, I will pose the question for them so that they can feel at ease to get the education that they need, feel comfortable about asking those questions, like Jocelyn was saying, to their physician, and being a little bit more proactive. And so even within my bubble of urology, a lot of this started with just men taking notice of their health and not waiting until something catastrophic happens before you understand that you need to go to the doctors every year or what have you. So, I always attack it just by being the voice and the ear, through education and to encourage. And it's one small step, but I think that if everyone took that approach, then at least from the side of misinformation and distrust, that we can eat away at that little by little.
And come to you, Amanda, for your insights about the health disparities we see within the Black community.
Yeah, so as I started off saying, I mean, this is not news to me in the world that I live in and the work that I do around HIV infection. Black people are disproportionately affected by HIV. The social determinants of health are so prevalent amongst that population. And so when I started working with the health department a year ago and calling people who had COVID and trying to understand what was going on in their households, and telling people you need to isolate and you need to, other family members need to quarantine and you can't go to work, and you're listening to people, and your job is to understand who's in the household. There are 5, 6, 7, 8 people in the household. There's one bedroom, there's one bathroom. People are maybe undocumented immigrants and they're not really, in the position at that time. Our leadership was a little bit different. And so they were worried about sharing information and worried about losing their jobs, or they didn't have money to pay rent, or they didn't have enough food. And so, all of those things came to light, and they're not new. They're things that we knew that we had to be able to provide to individuals, whether they're living with a chronic condition or whether they're living with COVID, and trying to get through those next couple of weeks. So for me, it was, a reminder of all of the work that we have to do. I also think it's been an opportunity for us to remind everyone that we have seen centuries of these health disparities and systemic racism. We've worked with the city council to try to declare systemic racism as a public health emergency and crisis in DC. And so hopefully that will continue to gain momentum. And, unfortunately, health inequities and disparities and, systemic incarceration, all of the things that we've observed over the last year, now's the time to really make sure that people are aware and are willing to do something to change it. So in some ways, COVID has presented us with an opportunity to hopefully make some long-lasting impact.
Thank you. Kai, I'd like to hear from you.
Sure. So I did mention the maternal mortality crisis that's going on in the city, and someone else mentioned, I think that was that Robia? Robia also mentioned across the country. It's a problem. It's a big problem. And, you know, one of the problems we're having is east of the river, where are people going for care? How are they going to get to it? And what happens if there's an emergency? Well, they have to go real far to get some care, right? I had a baby. Oh, another issue is people taking care of themselves in the middle of this pandemic. You know, I'm urging my mamas, go out, get some fresh air, get some sunlight. You got to make sure you're eating the right things. You got to make sure you're getting some exercise. You know, you can't compromise that blood flow. And people just aren't doing it. You know, people are depressed, people are at home, life is so different than everybody knows. And people are just not doing that. So I'm seeing higher rates of preeclampsia than I've ever seen. I'm seeing a lot more small babies than I've ever seen. And where I was about to go is going back to the access to care. You know, I had a baby that was born in Southeast, and this baby came out and was the smallest baby I'd ever seen ever at home. And again, part of that is I'm not seeing them in person for visits, right? That we are seeing them by ultrasound. We can take a look inside the belly, but that's, you know, it's limited. So the smallest baby came out, baby was not breathing, and I had to sit and breathe for this baby for about 20 minutes. It took them 20 minutes to get to us. Baby was sent to the hospital. Baby is fine. Baby is still fine. Baby has no brain damage, no issues, but that is a blessing. Like, that's almost a miracle. That is a miracle that that baby is okay, right? But that should not be the case. We should not have been in that home waiting for 20 minutes for somebody to come take this baby to where they could get some help, right? So, I mean, access is a big issue, but another issue is priorities. And who is the priority? Well, it depends on who's giving the care, right? I had a birth very recently where there was a mom who came in. She was 35 weeks pregnant, so she was early. We couldn't have her home birth that she'd been planning, but I was there virtually on a computer screen because they weren't allowing any healthcare practitioners in the hospital, right? So I have to be there virtually to support however I can. I was in a hospital that I go to all the time. It is an amazing hospital, great hospital. They take such good care of the patient. They all know me, I know them. I meet with them quarterly to make sure they're, you know, things are going well with our transports. And I had a mom who could not urinate. And when I realized she had not urinated in a while, I started making a big fuss because mom was getting to the point where she was ready to push her baby out. You should not push a baby out with a very full bladder. However, this mom was having a very difficult time trying to urinate. So I said to her, when's the last time you actually got something out? Now, being virtual, I couldn't see this for myself, right? When she went to the bathroom, I assumed she urinated. My fault as a practitioner. But she had not. And so when I said, well, when's the last time you actually went? She said noon. This was about 7 o'clock at night. And so I said, we got to get you catheterized. I called a nurse. I said, nurse, we had a brand new nurse at the time. I said, she has not used the bathroom since noon. We probably need to get a catheter, get her drained, and we need to get her comfortable so that she can comfortably push her baby out without any complication, right? She says to me, I'm sorry, I was talking to the patient. Okay. So then I called the doctor's station because I'm like, okay, she's clearly not doing anything here. Let them know who I was. I told them what happened in the room. They were appalled. They said, oh my gosh, we've got to get this bladder emptied. Let's do it. So I'm like, okay, we've got people on this mission. Let's do it. So by the time she got back to the room, they had changed the nurse, gotten us a new nurse, and they were appalled. This was a problem. Yet nobody did anything. But I'm still watching, right? I know the request has been made. I know they said it was happening. So I'm giving them a couple minutes to carry it out, and it still doesn't happen. I asked, and I know this because it was a Zoom recorded situation. I asked 8 times over the course of 1 hour for them to empty her bladder. And I don't think that they didn't want to. It seemed like everyone was about to do it, and nobody did it. And I kept saying, empty your bladder, empty your bladder. And then she was like, I have to push. Well, now we can't empty your bladder. She starts pushing, pushes the baby out. Bladder is so full that when it's time to get the placenta out, the doctor starts putting cord traction and the cord snaps completely. So now, that is a situation that's no good, right? Cord snaps, baby can bleed out. Cord snaps, blood's coming from mommy. No good, but all because nobody took the time to just do what needed to be done for this mom. And the interesting thing here is it's not about socioeconomic status. It's not about education level. These are really well-educated, well-to-do women who are just not faring well because they have the wrong color skin. So they are not priority to their providers. Maybe that's an unfair statement, and that's what I've been observing. So it's a problem.
That's very, very, very powerful testimony, Kai. I know we're getting short here. Robia, your insight on the disparities?
Sure. I mean, I could talk for hours, and I do, on the inequity for access to mental health care for BIPOC individuals, but to focus in specifically on eating disorders, because it is stereotypically considered a middle-class white female disorder. Eating disorders don't discriminate. African American females are 50% more likely to develop bulimia nervosa. And again, I could talk for hours about this. There's a specific reason why, and it has a lot to do with, historical and intergenerational trauma. But also, when presented with the same clinical case, African Americans are 17% likely to be diagnosed with an eating disorder compared to 45% of Caucasians. So if we're looking at eating disorders in particular, there's a significant inequity there. We're also looking at access to food. Oftentimes we have some of our BIPOC patients who are located in food deserts. And so what does that mean for them nutritionally? And I work with a team, and so our dietitians are not culturally competent dietitians all the time. And so how do we train dietitians to talk to a person who is brown about what their food is looking like? And they're missing the fact that all they have access to is canned food, and they're trying to get them to eat more fresh vegetables. That's just not going to work. And so there's a lot of stuff that goes into eating disorder care in particular that prevents a lot of BIPOC individuals from accessing that care, which is really significantly dangerous, because like I said, 50% more likely to engage in binge purge behavior, which has a lot of medical complications as well. So there's a significant inequity in mental health in general, but also with eating disorder care.
And Jeff, I want to come to you with that question as well, about this health inequities or the inequities in our healthcare system.
Okay, I want to broaden it out a little bit because
Absolutely.
I work on the res, and I'm dedicating this to my mother, the point of the spear who got me into Sidwell in the first place. And part of her family was Creek Indians. And as she got older and older and started to get Alzheimer's, she would say, "Go help your people." All right. Jumped up and went out to Navajo Res in 2009. Now in the Navajo Res, 30% of the people do not have running water, and 35% of the people do not have electricity. So when COVID hit, at one time, the Navajo Nation had the highest level of COVID in the entire world. Okay. And so that to say, again, thinking about the inequities, and now they've got some sort of control over it, but still you see the relationship between poverty, inequity, and COVID, right? And so unfortunately, what happens on the East Coast, you kind of hear about it, but you realize the Navajo Reservation is as big as West Virginia, right? So what you find, you don't even really hear about the inequities in Native Americans, particularly in those sort of places. And so again, I've kind of focused probably in the last 10 years more on Native American and Afro-American, but a lot of Native American, because they are truly neglected.
Thank you for that. And I want to wrap up here. And Jasmin, I want to give you the final chance to speak as the non-alum but on campus representative here, and take you just slightly in a different area here. Having been through what we've been through, obviously this last year, and all that we've seen, and all these other things, what insights do you have, or positives, or advice, or anything that you feel that we've learned from this that will help us be better?
That's a great question. But if you don't mind, I just really want to touch really quickly on the health inequity.
It's your
Because
show.
there's certainly, thank you, because there's a lot of stereotypical like notions of what school health is, right? A lot of people think a school nurse, we're just dealing with Band-Aids and vomit. And do we? Yes, right? But that's just a tiny portion of what we're doing. There's a lot of inequity in terms of how many nurses, or if there's even a nurse in a school. Some public schools, certainly, they share a nurse to 4 or 5 schools. The student to nurse ratio is way too high. Sidwell is very lucky. I'm very lucky to have literally 3 nurses and an athletic trainer that work under me. And so every student does get like one-on-one care, the follow-up, especially if anybody tests positive with COVID, the amount of care that we're able to provide. A lot of schools are not able to do that. And that worries me. And even still, with as many employees that we have working in my office, I still hit the wall sometimes when I do call a physician's office to talk about the care of a student. And it's always this one-way conversation of like, I can't talk to you, but you can tell me. I can tell you everything, but they won't be able to tell me anything. And that's not how we care for students. And it's definitely of students of color that I realize that there is just this barrier. And I don't know what that's about, but we continue to push. I also have to coach, just like Jocelyn was talking about. I have to say, this is what I need you to do. When you go to your doctor's office, ask for this, this, and this. There are times that they've asked me to just join conversations or join meetings with their doctor, and I can help, coach them through that conversation. So I just wanted to talk a little bit about that piece in terms of there's an equity there as well.
No, I think that's very valuable. Absolutely.
Yeah.
Absolutely.
Yeah. So in terms of lessons learned, I will say that, not to be cliche, but, we have to pace ourselves. There are times when certainly my days have turned from like 8 or 9 hour days to now 12 to 16, 7 days a week. And there are times when I'm exhausted, but then I try to say, okay, I need to stop, but then who else is going to do the work? But you have to take care of yourself. So that's one lesson. You have to take care of yourself first. Otherwise you are no good to anyone else. I also think that in terms of lessons learned is recognizing when you need help, and not having this, what we call the God complex, where you don't need anybody. I'm the expert. I don't need to, I've read all the research and I know everything. I always say, I don't know everything. And I will reach out for help to say, what do you think? Or even if I think I know, I still will collaborate with someone else to say, this is my thoughts. What are yours? Because I may be missing something. And then also just the last piece is in terms of really understanding why you went into the profession that you did, right? Certainly as my mom pushed me to become a physician, and I was like, no, I don't know that I want to do that. I didn't even want to become a nurse. I actually wanted to be a fashion designer. That's what I wanted to be. And my mother's like, no, you need a steady job. And I was like, oh, okay, I'll go to nursing school and then I'll figure it out later. And I literally fell in love with community health and just that idea to be able to give back and take care of others. So it's reminding myself why I went into the profession, because you can burn out very quickly, and being mindful of the fact that the collaboration piece and just loving what you do, right? And remembering the population that you are serving. Otherwise, you run the risk of like not caring for your patients in the way they deserve and what they need.
No, that's great advice. And by the way, I see you're fashionably attired, so you're manifesting your insight there. Anyway, thank you all very much. And Anna, I know we ran long, but hey, you had a feeling that I was going to go rogue anyway. So I appreciate it, and I'm honored that you asked me to participate here. I appreciate all of the folks who dialed in. Hopefully you got something out of this. I know I did. I feel like we could have gone another hour, frankly. But please join us the rest of the weekend. Anna, do you have some words that you'd like to close things out with?
Just a huge thank you to all of our panelists. We asked you to spend an hour. You spent almost 2, and we're deeply, deeply grateful for that. Thank you to everyone who was listening in tonight. And again, like Neville said, we've got activities throughout the day tomorrow. We hope you'll participate as your schedule allows. And just can't say it enough. Thank you. Wish you guys a wonderful evening, and we will hopefully see a number of you tomorrow morning. Thanks again, friends.